Sir, we are live.
Good afternoon. I think we are back again in the month of June. The month of June is called as Scleroderma Awareness Month. Scleroderma is considered relatively a rare problem. Rare in a sense, I can say 1 out of 50,000 to 1 lakh individual may get affected by this rare disease. It is a autoimmune disease where body immune system, for reason we are still not ascertained or still not sure, start attacking the skin, starts damaging the lungs, and in an unusual circumstances, also damaging the kidneys, etc., causing a lot of problems to the patient over a period of time. What exactly is the scleroderma, and why should we really know about this particular disease, and what is the reason why we invest so much of time in spreading awareness about the scleroderma? The reason is scleroderma is what we started learning 20 years before, that it is not a treatable disease. We have no cure for the disease. The patients, whether you treat or not, gradually deteriorates. May take 5 years, 10 years, maybe 2 decades, 20 years, but still no active treatment or treatment interventions can be done. That was the scene what it used to be 2 decades back. With the advent of science and understanding about the disease, we started realizing that if we pick the disease very early, before it can cause damages to the skin, lungs, or any other important structure, the treatment can be successfully done. And whatever the problem that could have happened in 10 years can be postponed sometime to 3 years, or maybe permanently can be abolished. So that being the case, so now there is a need for everyone to make, understand, and learn about the problem called scleroderma. What is this scleroderma? When we say sclero means thickening. Derma, I think most of you know, dermatologist means skin specialist. So it is thickening of the skin. So why did we give that word called scleroderma? Because main feature or a problem that is visible to anyone when we see this patient is the skin, which is usually otherwise shiny. If you remember, and if you can see, you can pinch the skin and pull the skin out. And this particular folding and pinching is not possible as the skin becomes thicker. So this usually, that's why the term we call it as scleroderma. And this can happen, usually starts in the hands, then on the face, sometime on the chest. Gradually it can involve every portion of the body which is covered by skin. If it would have been only limited to the skin as a scleroderma, we would have been very happy. But unfortunately, the same thickening process do occur in the gastrointestine, esophagus, making the motility of the food down the esophagus difficult, movement of the stomach and intestine difficult, and also the same thickening occurs inside the lungs, and as a result of which lungs become fibrous, what we call interstitial lung disease. And similarly, the same fibrotic changes in the blood vessels can occur that results in rise in the lung blood pressure, also in the kidney, causing the kidney injuries, etc. So that's how the word, what we thought scleroderma only limited to skin, we have understood that, and we have much earlier that scleroderma is not just a skin disease, it is a systemic disease. That's why we use often a term called systemic sclerosis, or the old term which we still stick on with as scleroderma. Scleroderma is not a disease which presents in one form. We have multiple forms. Very lucky one may have only one thin strip of skin being thickened, what we call as morphia or a linear scleroderma. And usually in these set of patients, with a very small percentage of patients, inside lungs and any other structure may be involved, but usually it is very much limited to the skin. Then we have something what is called as limited scleroderma, where the skin thickening occurs on the face, over the hands only up to the mid of the arm, but other areas are spared. Usually in this, the thickening of the lung is less, but the esophagus gets loosened out as a result of fibrosis and muscle mass loss. And also lung, instead of becoming thick, the blood vessel becomes thick, results in what we call as increase in pulmonary blood pressure or pulmonary hypertension. We call it as pulmonary hypertension. What we mean by pulmonary hypertension, like how we have a blood pressure on the outer circulation, that is where the left heart pumps. Similarly, right heart pumps to the lungs, and the blood which is circulated in the lungs, the pressure in that area is increased because the blood vessels supplying the lungs goes on thickening. As they become thick, so the pressure increases, that results in pulmonary hypertension. When pulmonary pressure increases, backward effect on the lung, the heart happens. Heart starts working ineffectively because of the increased pressure. That results in backwater pressure. Back pressure results in congestive cardiac failure or heart failure. So that's how the increase in lung pressure is going to have an impact on the backwards, leading into the right heart failure and other problems. So in a nutshell, this particular scleroderma, if we pick up early, we can reduce these fibrosis happening, these thickening happening in the lungs, thickening happening in the other parts of the body, which in turn can improvise the overall general condition of the patients, well-being of the patients, and the deterioration that could have happened to the patients. This all can, over a period of time, can improve. So we can give a good and a better life to the patients who suffer from scleroderma. So I think that has made you to understand these patients initially present with a very subtle sign. Some unusual patients may have joints pain. The joints pain may bring a quicker attention, and sometimes there may not be much joints pain. The skin may be slowly become little edema, that is become little swollen in the beginning, little painful. Pain is not so bad to interfere in day-to-day life. So in the beginning, so that puts us to neglect the disease. Slowly, if you see, the skin becomes shiny and thickened. And as a result of that, your movements becomes little slow and restricted, though not painful. It becomes restricted because the skin doesn't yield to whenever you try to make a fist or fold. And even the face structure starts shrinking. People start telling, why are you so shrunk? And your face looks shrunk. So you see that face shrinking, and even the opening of the mouth becomes little limited, and they have a sort of a snake smile because of the puckering of the mouth. And also the nose looks sharper because the face things becomes deep. So that gives a very early subtle signs if someone picks up. And someone can get a right referral to either a dermatologist who is well versed in scleroderma, or to a rheumatologist who knows in and out of the scleroderma. If we go to them, they do a test, what is called as, first they look at the skin thickening, general examination, which makes us to infer that there is a definite skin thickening, or skin being little change in its contour. And also look for the other symptoms in the form of difficulty to swallow, breathlessness, and auscultation should help us to find whether the lung is involved. And all those clinical findings or all those clinical features, when it is present, we usually ask for a test, what is called as anti-nuclear antibodies, which is positive in quite a substantial proportion of patients. In a sense, it's around 70% of the patients. And if it is positive, or even if it is negative, if we suspect scleroderma, we do a test called scleroderma profile, which looks into few of the autoantibodies like SCL70, TIF1, and antibody against ribnuc proteins, and varieties of similar antibodies when they are present. So they, with the clinical feature, suggest a possibility of patients suffering from scleroderma. So as soon as we think it is scleroderma, the next step as a rheumatologist, as a treating doctor, we do is to see for the chest. We look at the chest by doing something what called pulmonary function test, where the patient is asked to breathe his air into the emission, which measures about how much the lung expanding capacity is there, how does oxygen changes, how does the carbon monoxide changes, and those things are inferred to figure out whether lung is affected or not. If we suspect further, a HRCT chest will help you CT scan of the chest. And if not, we also do a echocardiogram just to see whether there is any changes in the heart and the pulmonary pressure. If those are all okay, then probably if it is limited to skin, probably we have picked the patient fairly early in the disease, or the disease could be one of the milder variety of a 10% where skin thickening occurs and very slowly, maybe 2 decades or 3 decades later, they may affect the skin. All are not lucky. It's only 5–10% of scleroderma will have such a slow benign course. Seeing the right things happening to few people, you cannot think that the things are all good in these patients. So it's best to pick the patients right very early in the course of the disease and treat these patients. What are the treatment we can offer? So the treatment that we have is, one is symptomatical relief. If you have pain, discomfort, breathlessness, or difficulty to swallow, reflux esophagitis, or anything, simple antacids and posture corrections. If there is a bluish discoloration of the skin, which is very commonly in the cold temperature where the skin becomes blue. I think that we missed in the discussion. One of the commonest symptoms, especially in the cold countries where these patients walk in, is the blue discoloration of the fingertips or the toes when you expose to the cold. Somehow in tropical countries, even in southern India, those symptoms are less. Even we do see it when they hold a glass of a cold water or work with the cold water, or whenever they do in the winter time, these fingers may turn white followed by bluish discoloration, what we call Raynaud's phenomena. And the drugs to treat that, we use calcium channel blocker, fluoxetine, and some of the drugs which are useful with reference to that. When there is pulmonary pressure is increased, we use anti-pulmonary pressure medications. If heart is affected, some cardiac drugs will help. And overall, to bring a control on the autoimmune disease process, we use drugs like azathioprine, cyclophosphamide, methotrexate, hydroxychloroquine, and cyclophosphamide. In a rare, difficult situation, drugs like biologics like rituximab, and off late anti-IL-6, the Actimera, another drug, and few new generation drugs are coming, which can definitely make a huge change to the patient suffering from scleroderma. So that being the case, now how one can live with scleroderma? That is one of the crucial questions that always any of these patients will have. When you have a chronic disease, when you know that you are suffering from a chronic disease, the first reaction comes to all of us are two. Number one, do I really have this disease? By mistake, the doctor did a wrong diagnosis. Fair enough. That's a good suspicion. Best to connect with a correct doctor. Please remember, never go by a wrong opinions. The reason why I say is, mind loves to listen what we would like to looking for, though it may not be the truth. So because if we are looking, everything is going to be good, we love to listen to someone who says a good things about, rather than someone really is warning or cautioning you about the wrong things which is likely to happen. So the reason is, mind love to seek something which you believe is truth, not necessarily that should be the truth. So that's why make a cautious decision to take a second opinion. When you take a second opinion, make yourself sure that you have contacted someone who is as good as the previous doctor who has given you the diagnosis. Once you are sure of the diagnosis, the next question comes is the denial and a sort of a guilt feeling that why did it happen to me? What sin I have done? I am such a pious woman. I don't smoke. I don't take alcohol. I've done all the right things of my life. Why am I on earth suffering this particular disease called scleroderma? I mean, let's be clear. No one wishes a disease to come, and no one curses you to have a disease. It all comes by chance. So it's because your genes, your environment, and a lot of other pressures and a lot of infections, everything, when it coincides to develop a wrong thing, the wrong thing happens. When wrong thing happens, the best part of us is to accept it. So we need to understand that A solution to a problem of any type, especially when it involves us or involves any one of us, is to accept that, yes, we have a problem or I have a problem. If you don't accept it and go on denying that, yes, I don't have a problem, solution never comes because the problem is not realized. And that's one of the major crux in most of these autoimmune diseases. Most of the time, we as a patient or anybody as a patient start denying that I don't have this disease, start believing that I don't have the disease, and try to seek to a solution where we feel that things can work far more brighter. So, but that's where we call it as realizing what can happen and what cannot happen. What I mean is, for instance, bad luck, you met with an accident, your finger got cut, and you are unable to track the finger where you can reunite or do anything of that, and your finger is amputated and cut off. Never expect it to regrow. It doesn't happen because we as a human being don't have a capability to regrow any organ that is cut. It's not like any other lizard or anything where if you cut the tail, they can grow back. We don't have that capacity. Let's be clear. So what we now need is, I need to accept that, yes, I don't have this third finger, fourth finger, which is cut by accident. It's bad luck. A disease of this nature sometimes occurs by many factors which can push an individual to develop into an autoimmune disease, so-called scleroderma. So first thing is to accept it. Once you accept that we have the disease, approach the right doctor. He will give you what are the current available solutions, what are the way to treat the disease. The treat the disease of a scleroderma nature is not a one-to-one. Like you have typhoid, start antibiotic, you're out with it. It's not that simple. You need to figure out what is the level, what are the organs affected, what are the other autoantibodies there, what you as an individual with other problems, like if you have diabetes, blood pressure or anything you can tolerate. And based on that, some amount of drug decisions are taken. If you comply with the drug, you definitely are going to get the best outcome. So each disease, each drug, each chemicals have its own effect, beneficial as well as non-beneficial effect, what we otherwise call side effects. So we need to accept both. Side effects, as you know, before any drug comes into the use, we test it. It is, of course, we test in animals first. Animals pass the test, then we test in humans. And in humans, if we have very less proportion of adverse event, then only the drug gets licensed to be used. With all these measures, we have most of the drugs which have 10% to 15% of the adverse event, with an exception of the drugs which I use in oncology practice when we treat cancer, because we don't have much drugs which lesser aggressive drugs. So that being the case, even there of late, we are getting less aggressive on the other tissues, but we do have problems that we need to work with, and we have a problem in the solutions too. And we need to put the both things right and figure out which is the best way out. A little exposure to risk with a solution rather than running and carrying on with the problem which has 100% risk. So based on all these decisions, if we take an appropriate and a skillful, well-discussed decisions, we can move ahead with the scleroderma. You can work with scleroderma, live with scleroderma, and can lead a normal life. Little disfigurement, little discourage here and there is always a part of life, whether it is be a good professional life or a bad professional life or a disease or anything to run through. So these are all the acceptable limits within which, if you really take the treatment, you can lead a near normal life with reference to scleroderma. I think with this brief positive note, lots have changed with reference to the management of scleroderma. I think one of my colleagues has previously discussed at length about the recent advances that has happened with reference to scleroderma. Putting all that together, definitely we have gone a long way in the management of scleroderma. Still, there is a long way to travel. We are aware about that. That's why still we accept the fact that we don't have a permanent cure for scleroderma. That fact is still kept boldly on our books, is basically because we need a lot of work and research that is required to find a solution. That science is progressing it faster. Lots of learning has happened in immunology and other molecular biology. In the times to come, we may be in a position to give a long-lasting solution. So keep thinking positive, work with your consultant and work with your rheumatologist, take the drugs in the right dose, in the right time, and in the right directions. Definitely, one can live a comfortable life with scleroderma. Thank you very much for your patience hearing, and I hope it puts all of us in a good spirit in this scleroderma day that we should face the disease boldly and we can definitely win this disease. Thank you very much.